Hey, welcome back. If you're just tuning in, you're watching the Arthritis Show, a global information source dedicated to patients with arthritis and sports injuries. Well, joining us today exclusively in our studios is Mr. Frank Musomeci. Did I say that right?
Yes, Doctor.
Fantastic. Mr. Musomeci is coming from Pritikin Longevity Center. Pritikin Longevity Center is world-renowned, and their specialty is obesity, right? And also,
we call it a longevity center. They address all venues of health, obviously nutritional, cardiovascular, metabolic health. And my role there, or my subset there, is I am their biomechanical consultant.
fantastic.
So I work jointly with them on some of the issues that we were just talking about. We do see a certain percentage of the people there are obese, and we do see that they may have orthopedic limitations to achieving their metabolic and cardiovascular goals. The knee being of particular interest, as you guys pointed out so well.
How common do you get to see the knee problem?
Well, here's what we do. We try to set up a program where we'll screen people that we feel are either at orthopedic risk or at some orthopedic limitations. So we do a biomechanical screening. We start at the foot. We look at overpronation. We look at valgus and varus. And particularly, we look at patellofemoral tracking, because we find that the patellofemoral dysfunction can also stop people from exercising comfortably. We may also address some of the issues you talked about, which was the amount of pressure at heel strike for the obese population. So we do some lighter impact exercises, and one of our favorites, in line with what you were saying, are water-based, and we even like the aqua jogger, where they're jogging unweighted with some friction shoes. This way they get to strengthen the muscles of the legs without the impact.
Fantastic. Yeah, the knee problem is one of the more common things that we get to see at our center and in my practice. So, and we do see the obesity being a big problem with that. Do you see that in your center?
Well, absolutely. First of all, it is always harder. In the rehab setting, which I also happen to work in the sport clinic, we see that the obese patients are harder to get our results with, obviously, for the forces you were just talking about. Heel strike during gait, they're multiplying their weight, and they're compressing their joints. So we know that. But furthermore, in the prevention setting, what we try to do is we try to prevent them from choosing the wrong types of exercises and winding up as a clinical patient. So the goal is, in prevention, trying to prevent people from destroying their joints while they're ironically trying to get into shape. And then in rehab, we're trying to get people back to the fitness world so they can be achieving their fitness goals.
Roman Garcia, what's your thoughts on that?
Doctor, I totally agree. But I have one question. For those folks who do not have access to a pool, what are the better forms of exercises that they can participate in with the minimal amount of trauma to the knees? Is there a perfect exercise?
Well, here's what I say perfect. No, I would say that each one we have to choose based on the set of circumstances we see with that particular individual. Now, for example, in our cardio room, we may even do things such as retro treadmill, which has less heel strike, strengthens the quads, absorbs the shock a little bit better. We have a new step. We use arc trainers, and sometimes we'll use some of the air resistance, Airdyne type bicycles. And we may use those instead of our treadmills for those people who may be obese and have compression pathology at the knee.
Is there one exercise that is absolutely, the risk-reward ratio is on the risk side? In other words, is there an exercise that you absolutely do not recommend as a form of exercises for those people who do have knee problems and for those who do not have them yet?
You know, I would tell you this. After a certain point in time in our lives, I believe, and the doctor can talk about this better, but the matrix of the cartilage, I believe, becomes a little more compromised in our 5th and 6th decades in life. And there, at that time, I try to discourage some of our guests who like running away from running, and I try to get them more into the lower impact exercise at that time. So if I had to choose one that I see just as much risk as I do reward, I would say it's running after 50 years old. That would be my opinion.
And for those folks, because we've seen this psychology before, where individuals who have been running for a very long time, if you mention anything about not running, they just will not hear you.
That's a great point. That's a great point. You know, and I'll tell you this, because they realize that one singular exercise addresses so many things, and so they really want to do it. So the way in which we try to do it with the ones that are still running without a problem is we try to give them the concept of cross training. And we say, listen, you're running, you're pounding your joints every day. If you looked at the cumulative amount of workload on that, that's an awful lot for your joints. What if we were to get you to do some, we call isotonically resisted retro walking, 1 day a week? And we do that with resistance, and they walk backwards and forwards. And we explain it works on balance, proprioception, it strengthens muscles, and it still achieves cardiovascular wellness. And we have them wear a heart rate monitor when they do that. So we like to get them to start thinking, we're not trying to eliminate running, we're trying to add other skills that have some neurological benefits, some balance, proprioception, and we try to incorporate other things to help them with their recreational life. But you're very right about that. It's so hard to get an avid runner to just stop running. So I ask them to start asking, let's add Arc Trainer once a week, let's add aqua jogging, let's get them to some retro treadmill, and once we have a matrix of different exercises, they don't get as stale muscular-wise. We get a little muscle confusion, which helps achieve some physiological goals, and we try to get impact off them. And if you look at the end of a year, if they're running once a week versus 4 times per week, and they're doing the other cross-training, I think the mechanical forces are cut down dramatically, and subsequently, a little less wear and tear in the articular surfaces of the joints.
Fantastic. I also wanted to interject here about running, because that is one of the, we see people who, we treat them and they want to go running next day. And the main reason behind that is, as you know, especially if you're a runner, you got these things called endorphin. These are proteins that are made by your pituitary gland. When you run, the level of endorphin goes up. This is a very good thing because endorphins are responsible for a variety of reasons, specifically immunomodulation or fixing the immune system. But when you run and you increase the endorphin, it gives you a natural high. And that's what the runners are after. They want to get this natural high. There is other ways to increase the endorphins, but you know, it's very difficult to talk people out of it, but definitely we feel that running is a risk factor for osteoarthritis in the knee. Just like you said, especially around age 50, you know, if you run aggressively, most likely you are damaging your cartilage. Now, a lot of people don't realize that because their quadricep muscles are very strong. And, you know, if your quadricep muscle is very strong, that takes some of the workload off of the knee joint. And so you may not get the pain as you're running, especially when you're running, you know, you're increasing also the circulation to your knee joint. When you increase the circulation to the knee joint, comes with your circulation and blood cortisol. Cortisol is different than cortisone. Cortisol is the natural hormone of your body produced by the adrenal gland, which are sitting on top of the kidney. And what the cortisol does, well, it causes anti-inflammation. So when you're running and you're feeling good, you know, because we hear from people saying, when I run, my knee pain goes away.
It's later they complain.
Yeah. The trade-off, however, is not worth it. The trade-off is you're feeling good for a few minutes, but you're wearing the joint off. Fantastic.
You know,
yes, go ahead.
Doctor, one of the other things we like to do is we like to make them rethink about the mechanics of their running. For example, we try to look for pronation if they're over-pronating and if they're addressing that through the proper running shoe. The next thing I try to do is get them to stop running on a street, particularly one that's uneven, because that has problems for their back. And then we talk
cobblestones. Cobblestones are very bad.
Even worse. And we try to get them to run on treadmills that have shock absorbency to them, not the inexpensive ones, but the ones that have some shock absorbency. But again, getting back to Roman's point, it is very hard to get an avid runner to just stop running.
Yes.
So I think if you talk to them about it and if you get them to think in phases of getting out of it, I think you're more successful with compliance.
Now, a word about treadmill machine. Most of the treadmill machines are already set in an incline, like a couple of degrees, and they keep increasing as you run on it. We tell our patients they can do treadmill machine as long as it's not an incline, as long as it's a flat surface. Because as I mentioned earlier, as you go against gravity, you put in more force on the joints, and therefore it may be counterintuitive to do it. Yes, Mr. Garcia.
And I've got one more question, doctor. How should somebody go shopping for sneakers? Is there something that they should look for in the sneaker?
Is there a particular sneaker that you recommend to your patients?
Or is that specific for each individual?
Absolutely. It is specific for each individual. The first thing we do there, when we do a biomechanical evaluation, we like to look at them in full weight bearing on one foot. So we like to see if there's excessive pronation. That seems to be the most common deviation, is the overpronation. So we like to control forefoot pronation to keep the foot in a more subtalar and talar curl neutral, which load bears a little bit better. Additionally, eliminating the overpronation also eliminates the excessive internal rotation of the tibia, which puts more wear on the tibiofemoral articulation. So we like to look at that as being one of the keys. Now, the next thing I typically do is I ask the people to go to a running store where the person knows how to assess what foot type it is. Because many people will go to a store in a mall somewhere and they will pick a New Balance shoe, which is an excellent brand, and they'll pick a model number. And I'll say, well, why did you pick the 929? Oh, because I liked the way it looked. Well, that particular model number was typically designed for motion control maybe, and maybe you don't require motion control. So the next thing is we look at that. If people are going to be walking for exercise, we like them to get the walkers rather than the runners because they absorb a little more shock at a slower speed. So we try to get a little particular about those. We may even talk to them about insoles and things that absorb shock very well, like the Viscoped product, which happens to be one of the very soft ones, or Spencos. So we try to get them to think in terms of absorbing shock for exactly what you both were talking about, and that is this cumulative microtrauma over time really accelerates wear and tear on our joint surfaces.
And what signs should they look for in a sneaker to tell them when it's time to change them?
You know, that's a better question asked, I think, to a podiatrist, to be honest, than me. Yeah, but we look at it, if they're unevenly worn or if they've lost some shock absorbency to them, I would say to you that, leaving them too long is always a problem. That we know. At the same time, I'm not a good judge of sneakers as far as how long.
Can they go by miles?
I don't know that. I honestly could not tell you that.
Okay.
One particular sneaker that we do recommend to our patients with the knee problem or hip problem or back problem is the Shape Up by Skechers. They have that biomechanical. Exactly.
They absorb shock very well.
We feel that that's very good.
I've worn them myself. I found them very comfortable.
Myself too. I wear them and I like them. So that's called the Shape Up by Skechers. We feel that has been helping some of our patients. At this point, this is all the time we have for you today. I want to take a moment and thank our guest, Mr. Frank Musomeci from Pritikin Longevity Center. Thank you for coming.
Oh, thank you for having me, Doc. Pleasure. Pleasure, Robin. Thank you.
Make sure you join us for our Friday show. As usual, we'll bring you the latest in arthritis and sports injuries. Have a great day.